Welcome to Area Plux's MRB recall. With great happiness, I am here to share that actually this MRB RRR series of Area Plux's, many questions have come from for this exam, and I hope the students have done this exam well. Let's go to this recall. And before going to this recall, actually I'm here to Dr. Vimal here to discuss with you the pathology questions. And here to say that 18 questions have come from the pathology series, like what we have discussed during our MRB RRR and during the leaderboard and the practice paper. So through various programs actually incorporated in this MRB series which we incorporated, a lot of questions have come from this thing. And out of this 18 questions, 16 questions are directly from the discussions and the remaining 2 questions actually are from the regular workbook series. So once again, pathology has become the game changer in this exam. So let's see this pathology questions with also the screenshots from the things what we discussed in our MRB series. So let's go to the first question. Hurtle cells are prominently seen in. So Hurtle cells are prominently seen in, they have given the options are Hashimoto thyroiditis, Riedl's thyroiditis, Decurvens thyroiditis, subacute thyroiditis. So let's see what we have discussed in our workbook. In the MRB workbook page number 55, we have discussed this Hashimoto thyroiditis, and I hope you remember that we have discussed about this Hurtle cells, which are these large cells with abundant eosinophilic cytoplasm, which are called as the Ashkenazi cells or oncocytic cells. So as I insisted, this Hurtle cells is a potential one which can be asked in our exams. Exactly, they asked the same thing. So Hurtle cells are seen in Hashimoto thyroiditis. And Riedl's thyroiditis, Decurvens thyroiditis and subacute thyroiditis, Hurtle cells will not be prominently seen. So it is Hashimoto thyroiditis. Now let's move on to the next question. The sites of endometriosis are. So here they have given the sites as ovarian endometriosis, rectovaginal endometriosis, umbilicus and scar. And the fourth option is all of the above. As you know, like we discussed in our workbook series, again in the page number 52, we have discussed about the endometriosis of the ovary, that is in the chocolate cyst, and I hope you will also remember that similarly the chocolate cyst was asked in the radiology question also. So let's see this rectovaginal endometriosis also, like in the pouch of Douglas also, this endometriosis can be there. And scar endometriosis is one of the common entity actually we can encounter during the clinical practice. So sites of endometriosis includes ovary, rectovaginal and also umbilicus and scar, making this fourth option is the correct one. Sites of endometriosis, all of the above is the correct one. Now let's move on to the third question. The most common type of shock present in the trauma. So in the trauma, usually you expect a heavy blood loss. So there will be a fluid loss. The other options they are given are hypovolemic shock, neurogenic shock, obstructive shock and a cardiogenic shock. Let's see the question which we discussed in our leaderboard day 2 and 24, discussed about the different types of shock. So let's see this. Actually we have discussed like hypovolemic shock caused by fluid loss with increased systemic vascular resistance to maintain the perfusion, which becomes the most common cause of this shock in a blood loss. So the most common type of shock present in the trauma is hypovolemic shock, because of the volume loss. Coming to the fourth question, chronic inflammatory reaction are all except rheumatoid arthritis, pulmonary fibrosis, atherosclerosis and sepsis. So we all know that at various points during our discussion we insisted about the features of chronic inflammation, and regularly you will be hearing this word from me. The hallmark of chronic inflammation is the fibrosis. So pulmonary fibrosis is become a chronic inflammatory condition, and rheumatoid arthritis, obviously it is a chronic inflammatory condition, And atherosclerosis, which is a degenerative process, is also a chronic inflammatory condition. So as you can see from our various leaderboard discussion, which was in the leaderboard 8 to 24, we insisted that rheumatoid arthritis is a chronic inflammatory condition. And also this subject wise test also we discussed that this atherosclerosis is a chronic inflammatory process. So directly ditto the same word to word the questions have been asked, and making this sepsis is not a chronic process. Yes. So septicemia, bacterial sepsis, so is an acute process. Rest of all the things are a chronic inflammatory reactions. Rheumatoid arthritis, pulmonary fibrosis and atherosclerosis. Moving on to the fifth question. Among the primary malignant parotid tumors, the most common one is, so insist, please listen this question carefully. So they have asked about the primary parotid malignant tumor. They have not asked about what is the commonest primary tumor. So malignant tumor, the word specification tells you that this is a case of mucoepidermoid carcinoma is the most common malignant tumor. And please see this in our leaderboard day 12 to 24, we have discussed exactly the same thing. Mucoepidermoid carcinoma is the most common malignant salivary gland tumor. Yes. So moving on to the sixth question. Pathogenic T lymphocyte response and granuloma formation are the potential mechanism of vessel damage in all of the following except. So they have asked about in which vessel damage, tells you that this is a case of vasculitis. So what are all the vasculitis where we get this granuloma formation? So as you can see, like on various practice papers, we insisted about the vasculitis, like granulomatous with the polyangiitis, and about the vasculitis associated with the granulomas. So you can see here giant cell arteritis, definitely there will be a granulomas destructing, and you know that temporal arteries are the commoner artery which is affected, which has a granuloma. And here the eosinophilic granulomatosis with polyangiitis tells you that the word itself is a granuloma. Granuloma is the Church-Strauss syndrome, and also you will have this eosinophil. Takayasu arteritis, which is a close differential for this giant cell arteritis, is also associated with a granuloma. And remember the question asked about except. So serum sickness and cutaneous vasculitis syndrome will not have a granuloma formation. Rest of all the vasculitis will have a granuloma formation. Vasculitis with granuloma formation. Moving on to the seventh question. One of the following is not an immune complex mediated hypersensitivity reaction. So immune complex hypersensitivity reaction means it is a type 3 hypersensitivity reaction, where the classical examples are serum sickness, Arthur's reaction and SLE. Coming to Goodpasture syndrome. What is this Goodpasture syndrome? Antibodies are directed against the glomerular basement membrane as well as the alveolar capillary basement membrane. So the patient presents with hematuria and hemoptysis. Some of you asked me this doubt, that is a Goodpasture syndrome. Again, it is an antibody is destructing the antigen. No, then antigen antibody. No, then why can't it be an immune complex? But dear students, please remember, here the antibody is destructing the GBM. Destructing. If something is destructing, what I told, cytotoxic. Yes. So the antibodies are destructing the glomerular basement membrane. So making this Goodpasture syndrome is a type 2 hypersensitivity reaction. So it is a cytotoxic reaction and not an immune complex. Whereas the serum sickness, Arthur's reaction and SLE are the classical examples of type 3 hypersensitivity reactions, which we discussed in our various MCQs. So please see this. Anti-GBM antibodies, we say that it is a hallmark of Goodpasture syndrome. We clearly mentioned in our workbook that immune complex deposition is more characteristic of lupus nephritis, and we said that it is not seen in this Goodpasture syndrome. So exactly that's typically the same question has been asked in the exams. So let's move to the again many of you will be saying that serum sickness, 2 to 3 questions the same thing around the serum sickness has been asked. Let's see the 8th question. Serum sickness is a systemic form of hypersensitivity belonging to which of the following type of hypersensitivity reaction? Yes, from the previous workbook, previous page itself, we have seen this. Serum sickness is a type 3 hypersensitivity reaction. Yes, that is the classical hypersensitivity type 3. Again, it was the question asked in the question 29 in the leaderboard date 6 to 24, where we have said that type 3 hypersensitivity reaction, the classical examples are SLE and serum sickness. So if you had gone through this MRB leaderboard questions daily, you would have practiced. Definitely this would have been a cakewalk for you for the exam. So moving to the next question. In disseminated histoplasmosis, the histological features identified as. So this is a straightforward question. They have asked what is the histopathology of the disseminated histoplasmosis. And see this in the practice paper 3, the question number 49 says that exactly the same thing. Or in histoplasma capsulatum, what are the definite features? So this is the oval budding yeast inside the macrophages. So in the tissue biopsies, oval budding yeast within the macrophages, that is exactly the same question is asked this. So accumulation of mononuclear cells filled with yeast. Mononuclear cells are nothing but these are all the macrophages. So in histoplasma, you can see in the tissue biopsy, the macrophages would have engulfed this histoplasmosis, yeast forms. Yes, the same thing has been discussed in this workbook. And the most common site affected by genital TB, yes, this is all the place like where we insisted most, and many places we have insisted, and one of the example here is like leaderboard 4 to 24. Actually, we have discussed this about the female genital tuberculosis, where we have highlighted that actually it is the fallopian tubes or the most common affected site in the genital tuberculosis. Yes, this is a straightforward question, and obviously we have discussed in our exam. And coming to the next question, at puberty, the number of ovarian oocytes is. Yes, this during our regular classes also we have highlighted this point about this ovarian oocytes, especially I would have highlighted during the Turner syndrome discussion, and also in the MRB leaderboard 4 to 24 also the question actually highlighting this concept. When does the ovary contains the maximum oogonia? So in this question actually we highlighted that in the 5th month of IU life the ovary contained the maximum oogonia, and we said that this oocytes number dropped to around 1 to 2 million by birth. So it is around 1 to 2 million is by birth itself, only 1 to 2 million is there. So definitely at puberty it keeps on reducing into 3 lakhs. Yes, and also highlighted during this Turner syndrome. By actually this Turner syndrome has an accelerated loss of oocytes. So the Turner syndrome patients will have the loss of oocytes around some 2 years or 3 years itself. The ovary will be completely lost of oocytes. So what is the term we use? That menopause before menarche, because the ovary would have lost all the oocytes. So you'll be getting streak ovaries in the Turner's patient. And that is the phrase actually menopause before menarche is applied to this Turner syndrome. This context actually we have also discussed during our regular classes also we have discussed this point. Yes. So moving to the 12th question, again a straightforward question, Peutz-Jeghers syndrome, inheritance. Many times we have discussed during our sessions, and also we have given a subject-wise test in the pathology also, which highlighted a question about this Peutz-Jeghers syndrome, about in this thing. All of the following are true about Peutz-Jeghers syndrome except. So we know that it is associated with autosomal dominant, mucocutaneous pigmentation, and hematomatous pollen. Yes. So we know that the mode of inheritance of the Peutz-Jeghers syndrome is autosomal dominant. Yes. Moving on to the 13th question, hallmark translocation of the follicular lymphoma is. Once again, one more question from our direct workbook. Can see this with a proof that the practice paper 2, the question number 94, that asked about the BCL2 is the marker of follicular lymphoma. So if you could see this explanation, we have highlighted that this BCL2 and also this chromosome 14 and the translocation 14-18 is characteristic of this follicular lymphoma. So we remember we highlights this follicular lymphoma means it is BCL2 as well as the translocation 14-18, which we asked in the question 94 in the practice paper of the ADA plexus workbook. So the answer for this question is translocation 14 and 18. Moving on to the 14th question, thromboangiitis obliterans has the following features. Highlighted the word except. Yes. So the options given are occlusive disease of small and medium-sized arteries, affects large arteries, common in smokers, thrombophlebitis of the veins. As you could see this, the first two options itself are contradictory. One option is saying that it says that small and medium-sized arteries, and the other option says that it is a large arteries. Let's see what we discussed in our workbook. Actually, in leaderboard on day 10, 24th, question number 26. We have discussed this about this thromboangiitis obliterans as a clinical scenario based question, and also we have discussed about everything about this thing, and we highlighted that it is a medium, small and medium sized arteries and veins. They're exactly the same word they have asked in the question. So obviously this is a small and medium sized arteries common in smokers associated with inflammation of the veins. So it is not affecting the large arteries. That is the wrong statement. Yes. So moving on to the 15th question. Examples of systemic autoimmune diseases are all except. So the first option says systemic lupus erythematosus. Yes, so the word itself says that it is a systemic. The second one, rheumatoid arthritis and polyarthritis nodosa, the third one. All are systemic autoimmune diseases. Guys, if you remember about pernicious anemia, what we discussed during our leaderboard on day 10-24, question number 20. We highlighted that pernicious anemia mainly affects the stomach, where there is destruction of the parietal cells leading to the impaired absorption of the B12. So definitely it is not attacking the systemic response. It is showing mainly this, the organ affected here is the stomach. So pernicious anemia targets the stomach, gastric mucosa, parietal cells. Whereas the other options, you can see this rheumatoid arthritis, SLE or polyarthritis nodosa or the systemic diseases. So the correct answer marks here as pernicious anemia. Moving on to the 16th disease. As you could see, these are all the things directly from our MRB regular series workbooks. The remaining the three questions. The pulseless disease is also called as the AS. You can see from the screenshot from our regular workbook. So Takayasu arthritis is the pulseless disease. That is a very straightforward question. Yes, out of all these diseases, all this vasculitis, because Takayasu arthritis mainly affects the subclavian vessels. So, and you know the branches of the brachial and the upper limb mainly is derived from the subclavian vessels. So Takayasu arthritis is classically called as the pulseless disease, where the patient upper limb BP and pulses will be low, and whereas the lower limb BP and pulses will be normal. Yes. And in the class I used to highlight, if you remember, this is exactly the opposite of the coarctation of the aorta, where the upper limb BP pulses will be normal, and in coarctation lower limb BP pulse will be low. Yes. And moving on to the 17th question. The only blood cell that enters the blood again and again from the tissues. Yes. This during our class on inflammation, actually we remember in the page MRB workbook page number 4, actually we discussed during the cellular events of inflammation that it is mainly the neutrophils, the blood cells only will be coming, neutrophils only will be coming out, and it stays in the tissues. Similarly, eosinophil and your monocyte, the blood which come to the tissue, you call it as a macrophage. So once they come to the tissue, they stay there for a long time, and they stay remaining for a lifetime, they stay there only. But the lymphocyte is a cell which again and again it comes to the blood and from the tissues. So it keeps on mobilizing itself from the blood as well as the tissues. So the correct answer is lymphocyte. And the 18th question, again from pathology, again from our Adiaplexus series. Iron absorption in the duodenum is regulated by. If you could see our regular workbook, these things, you can exactly the same word. Hepcidin is the principal iron regulatory hormone, and it is negatively regulated by the ferroportin. You remember this picture in our regular workbook. Actually, this plasma hepcidin, it inhibits the ferroportin. So plasma hepcidin inhibits the ferroportin, thereby it mainly regulates the iron absorption in the duodenum. So guys, these are all the questions which we encountered in pathology from this MRB series. I hope you have done this exams well, and once again it feels a great sense of happiness to see that actually what are the questions we discussed in various forms, whether in the leaderboard or in the practice paper or in a regular workbook series and in this RRR series. So like when the questions are repeated, it's actually the students, when you call and say us, so we have done the exam well, it is from the MRB series it came, so it sends it feels that happiness. So thank you for calling me and sharing your happiness with me. So wish you all the best for your upcoming days. All the best. Thank you.